Jæja, kæru vinnir, dear friends, near and far. It's Friday again, and we have with us a distinguished guest, Timothy Skinner, from Australia, but now from Copenhagen.
Yeah.
Copenhagen.
Yeah.
One of the main challenges, one of the prime examples of longitudinal care of diseases is the care of diabetic patients. It is one of the best models of multidisciplinary approach in medical follow-up. You will be telling us something about how that works and maybe sometimes why it doesn't work.
Yeah, maybe a little bit.
Thank you.
Hi. So yeah, I'm a professor of health psychology, currently at University of Copenhagen. My Danish is not very good yet. I am trying with pronunciations, but that's about as far as it goes. I just wanted to acknowledge, I'm actually here on a University of Arctic North to North Fellowship for building relationships between the university, two universities here, and your own university here. So that's actually funding the visit. Now, although I'm based at the University of Copenhagen and I grew up in London, I just wanted to kind of touch a little bit about what's the reason why I might be here, is because for the past 11 years, I've actually been working where these green dots are in remote parts of Australia. And so I've actually, over the past 12, 11 years, kind of developed a passion for the issues around remote healthcare, delivering services into remote and rural communities. And actually, I was just come off the phone at 6 a.m. this morning. So we've got a diabetes project running in these 4 communities just here still. So I kind of have some connection to the issues around remote healthcare. And I predominantly work in diabetes, both type 1 and type 2 diabetes research. So I was thought about this. I've got a challenge of trying to give a psychologist trying to give a talk that's going to be of interest to everyone in the hospital who might be here. Not many of you, all of you will be interested in diabetes. So I can try and make it a bit of seasonal relevance and hopefully of value or use. And one of the pieces of work I've been involved in is the fact that we see substantial differences in outcomes between hospitals and healthcare service organisations all over the world, both within countries, within small regions. This is just one quick example. I went onto, there's a site you can go to in the US called Compare Hospitals, and you can randomly pick 3 hospitals and then compare them on a whole range of indicators, free of charge. So this is just looking at percentage of patients who receive appropriate care for severe sepsis and septic shock. And you can see this is a national average, the state average, and these are just 3 random hospitals I presented. And you can get this data for increasingly number of indices. So this is just one example. And we see these differences are across all sorts of procedures, whether they're medical procedures, surgical outcomes, or non-surgical outcomes. We can produce lots of these different indices, and they are very robust differences. Even when we control for case mix, demographics, resources, we see substantial differences in outcomes between healthcare service organisations, both between countries, and within regions. And this is just one example within GP practices as well. They're consistent, and it's one of our biggest challenges. Why do we get such varied outcomes in places with similar resources? Just bringing it into diabetes, this is a paper just published last month about Germany, and this is just looking at different outcome markers for diabetes control across different regions in Germany. We see substantial differences in that regional variation. And we see these not just in the outcomes of care, but we also see them in the processes of care. And I think I'm a great believer in, I don't know if many of you know about it, the BMJ Christmas research papers, the edition papers where they do these slightly odd research papers. I think one of the nicest ones that shows differences in health outcomes is this one was published in 2016, where they surveyed paediatric departments on Christmas Day, and they looked to see which ones had Santa Claus visit. And so what we see here are regional differences in the likelihood of Santa Claus visiting a paediatric department over Christmas. And what was interesting, they showed that Santa Claus attendance was not associated with school attendance rates in that postcode, was not associated with criminal conviction rates in that postcode, or distance to the North Pole. It was associated with socioeconomic deprivation, but that still didn't account for all the differences. But it's just for me, it's just a really nice study to show we see these differences in outcomes in a hospital setting, in healthcare centres, on all sorts of markers and indices. So we got involved in doing this work because of the Viva Childhood Diabetes Study Group. This was a group that was set up back in 1992, supported by Novo Nordisk. This is at their first meeting. Sorry. And they were basically set up with a simple mission to kind of stimulating research around improving the quality of care and knowledge around childhood diabetes. And what their first study was 21 departments of paediatric diabetes in 17 different countries. And they first did a sampling period in 1995 with about 2,800 0 to 18-year-olds. HbA1c was analysed centrally, so they collected a blood sample and then it was shipped to Steno Diabetes Centre in Copenhagen for a centralised assay, and they collected all these demographic outcomes. So we had classic clinical caseload mix, and what they found were massive differences in the outcomes of the paediatric centres in these 21 centres. So, you know, you're looking here between the centre that's got the worst average HbA1c, it's several standard deviations worse than the centre with the best HbA1c. And this was their first study, this was their data back in 1995, and then they replicated that in 1998, fairly similar sample. And what they found was those changes were still there. Those differences were relatively robust. There were some improvements in some centres, other centres got worse. But in summary, what they found that 3 years later, the 3 centres had improved significantly and 4 centres had deteriorated. 1 centre changed from being below average to being above average and 1 vice versa. But 14 centres did not change their position in that rank ordering between those centres. And thus they were arguing that these centres, among centres, were a reproducible finding. They also demonstrated with these 2 studies that these differences could not be accounted for by the gender mix of patients, the age mix, the socioeconomic status, the percentage of patients from a migrating background, family structure, so they've got 1 parent at home, 2 parents at homes, that kind of thing. It wasn't accounted for by clinical indicators such as what insulin regimes they were using, or the age of diagnosis, their insulin dosage, duration of diabetes. And it wasn't predicted or effect related to service features like whether there was a 24-hour helpline, the staff to patient ratio, the staff mix, whether there was a psychosocial professional, their funding structure or size. So they had these sustained substantial differences between centres that they couldn't account for with any of these factors. And it was this point when I was asked to join the Viva study group, and I'm actually the guy there hiding in the back. In there, and it's called the Vida Childhood Diabetes Study Group because we used to meet once a year at the Vida's Palace, which is a conference centre run by Novo for planning and doing studies. And I was invited to join the study because they basically said, well, it must be something psychological or social. It must be something to do that we haven't looked at. And so I was involved, and we decided that we needed to put all these psychosocial measures in. So we set about designing the 3rd study. And we measured general things like diet and activity, homework, toothbrushing, family environment, and emotional well-being from something called the Health Behaviour in School Children's Surveys. This is a World Health Organization survey that's done globally about every 5 years. The tools are validated in all the multiple languages already, so we could use this. Because we were arguing, well, maybe it's to do with the diet in those countries and their general lifestyles, because their cultures have very different, and that might be causing the challenges. We've done toothbrushing because actually it's a very good predictor of all sorts of health outcomes. Regular toothbrushing is a very good marker for lots of positive health outcomes. Family environment, so how much conflict there is in the family and how much support the family experiences, because there was particularly the Italians seem to think that this was a big, the differences in family culture and lifestyle and well-being, and then some diabetes specific tools we were going to put into the survey. So we got these psychosocial things going in, and we decided to go in there. But at the same time in the US, there was work being done on what's termed the clinical microsystem. And what they mean by a clinical microsystem are these small, discrete clinical units that sit within the hospitals and with our healthcare service units, so the intensive care unit, an operating room, the paediatric diabetes clinic, etc. And looking at what makes these systems effective. And so what they did in the US is they went around looking for teams of clinical microsystems that were recognized as examples of excellence by very diverse indicators. And they went for outpatient, surgical, intensive care. They went for lots of different places which were recognized as centers of excellence based on their outcome data. And they looked for what things were similar across all of these very diverse contexts of care. And they ended up coming up with, basically, there are 4 key things that flag up these centres of excellence. One is the organisation is around the leadership of the organisation, the very strong patient focus, staff focus, an interdependence of the care team, very strong focus on professional educator and training, and a very focused, outward-reaching community focus, good information technology, consistent application of performance and improvement, and these all things connected together. And being a psychologist, of course, I was particularly interested in this theme around the interdisciplinary team, and particularly this theme 6, the focus on interprofessional learning and team-based care as part of the improvements. And so rather than just focusing on the individuals, I was trying to persuade the group that what we should do is do something around assessing what's going on with teamwork. There is a clinical microsystem assessment tool. This is just part of it. And I was trying to say, well, we should be using this because this seems like might be a really good idea. And basically, it's a very complex tool, very difficult to translate into 21 countries. And people were just not that keen on including it in the study. And so I was having struggles trying to find a way to think about how do we engage some kind of assessment of how well the team works together within this context. At this time, I commenced a job at the Leicester Diabetes Service, where I was working half-time as a clinician and half-time as a researcher within the team. And so 2 days a week I was working with the paediatric team, and I'd been there for a couple of months. And I'd started off just by sitting in the clinic with all the different nurses, the dietitians, the doctors, and I sat in all the clinics with all of them and just getting a sense of how they do things. And then we were having a clinical staff meeting, and Peter Swift, who was the head of the paediatric diabetes service, without any preparation, simply said, okay, you sat with all these, what have you learned from sitting in with all of us? So I was put on the spot, and I said, well, the first thing that strikes me is you all contradict each other when you talk to patients. And he said, no, we don't. And I said, well, I'll just run a small experiment. So I gave everybody a piece of paper, a sticky note, and I went round and I said, I want you to write down what you tell patients is the target fasting blood glucose and target HbA1c. There's 9 people in the team. We then just stuck the answers up. We had 8 different answers. And so Peter then went, now we have the question to ask to look at team outcomes in the next study. Let's just ask what their blood glucose targets for the healthcare professionals are. So we added this into our tool. And so in 2005, we did same centres. Again, we got similar outcomes, very little change in outcomes between the 1998 survey, the 1995 survey, and our 2005 survey. There's a couple of centres that actually are showing significant improvements that we've flagged, but generally the rank order was the same. Still 13 years after the first study, no changes in the relative performance, despite the fact that all made huge changes in the insulin regimes they were using and lots of care structures. And once again, we found that the type of insulin therapy per centre had no impact on centre differences. Absolutely didn't account for any of the differences that we saw between centres. We found that physical activity, and whether we looked at it as the cultural norm or the individuals in the diabetes with diabetes, or the discrepancy between the two. So one of our theories was that if your culture is one of very low physical activity, so maybe Scotland, that actually patients would experience more distress because about trying to be physically active and it'd be harder. Again, we couldn't find any relationship between physical activity and those centre differences. We couldn't find any difference, so that last one was diet, this one's the physical activity. We couldn't find any differences for diet or physical activity. So they do predict HbA1c, BMI, etc., but they predict in every centre, and there's no difference. So they don't account for any differences. And we found family factors. Yes, they predicted HbA1c, they predicted emotional well-being, but they did that in every centre the same. They had no impact on centre outcomes. The only thing we found that had any relationship to centre outcomes was the amount of agreement in the diabetes team about what were the blood glucose targets. So what we see here is a slide where we have the centre's mean HbA1c and the team's responses to simple question, what is the target HbA1c? And we have 21 teams, and I think we've got only 1, 2, 3, 4, 5, only 6 where everyone in the team agreed with one another about what this marker was. And we asked them several other questions about frequency of blood glucose testing you recommend and various others, and the data is the same for all of them. And what you also see in this graph is that the lower the centre's HbA1c, the greater the tendency is for the team to say a lower target.
Yeah. Did you use trusted education? Like Daphne, did that make any difference in your centres?
At this time, when this study was, Daphne wasn't around at that time, but some of the centres are doing very structured education programs, some of the centres aren't doing very structured education programs. Some of the centres have got quite high numbers of patients on a basal bolus regime or pumps, others don't. And in this particular study, one of the interesting things is this centre here, up here, I'm not going to hide it, everyone knows, it was a centre in Brussels, actually had the lowest use of multiple daily injections. It was actually predominantly using a twice daily free mixed insulin regime. But they gave lots of individual education to those patients because to use that regime requires a lot of complex decision making, but they did a lot of one-to-one education. But you also see everyone's saying the same target and everyone's saying it's a low target. And what we actually found is that when we looked at our data is that this was the only variable. So we actually did two things. The team's agreement and the interaction between agreement and how low they set the target was the only thing that we found predicted differences in HbA1c or outcomes between centres. So we fed the results back to the centres. So we told them about this and thinking that what would happen is the centres would then work on building their teams and working together, improving outcomes and get better at that. So having given them a few years to work on it, we then did our 2009 study. Same methodology, everybody in those clinics, relevant clinics, are signed up, same centres. We've got a few different centres and a few centres have dropped out because of the clinicians retired and a few new centres come in, but we see predominantly exactly the same result. And for the centres that are in the study in 2005, 2009, again, predominantly no change again. We've given them this feedback. And so we asked them the same question again. And what we see is we're still seeing, this is the differences, the team members were asking them what would be a realistic target and an ideal target. And we're basically seeing the same kind of thing. And what was very interesting is the teams that get worse outcomes have more disagreement and setting higher target HbA1cs. And if we look at centres that have changed in their relative ranks, what we found 4 centres who have actually got worse. And in those 4 centres, you can see they've actually gone to have more disagreement in the team over the period. And the 2 of them, their target HbA1c, they've said is higher than it was 4 years ago. We have 3 teams that got better. 2 of them you can see they've actually got more agreement now in the team. They've got, well, this one's got more agreement, this got less agreement, but all of them, their goals, their target goals have started to shift to a lower amount. And we found again, the only thing that predicted differences in outcomes were these centre differences. And what we found is not only did we see here that we've got differences in the healthcare professionals, but what we actually also found is that related to variation in what the patients were telling us. So if we ask the patients what the targets are, centres that have poorer outcomes have patients that actually have more disagreement around and higher levels of target HbA1c. So if we want our clinical systems to work, we need some degree of consistency. We need the teams and people to be telling everybody the same thing. I'm a big fan of Simon and Garfunkel, a song the boxer, a man hears what he wants to hear and disregards the rest. So if we create those opportunities, people will disregard that inconsistent information. And the odds of a multiple team all telling people the same thing are remarkably low. And then when you bring in primary care-based and hospital-based people all trying to do the same thing, we get lots of inconsistency. One of the things that did happen, though, as a result of the first one where we showed the differences, is the Swedish decided to take this seriously and got funding to look at, first of all, they demonstrated differences in centre outcomes within the Swedish paediatric centres that were doing diabetes care. So they published this data showing they had those centre differences. But what they also did is they put in a quality improvement programme to look at trying to improve the outcomes. And they published this really nice paper like highlighting these were the different things we looked at and the different things done by the different hospitals. For me, the interesting thing is the 3 most things that was done in most centres. I think there's only 1 or 2 centres that didn't do these. Focusing on improved teamwork, information and communication education, not just with patients, but between each other, and actually going through and making sure they have a standard set of guidelines that they're all reporting to. And over an extended period, and they've now got data over 3 years, they've actually shown that this was kind of the purple line is the map of the centre differences when they started, and then green is where they are now. And what you can see, there's been a substantial reduction in the variability between centres. And they've only focused on those, most of those centres have focused on those 3 things as their priority. And as a result, you can actually now see, this was published, I think it was April, these are the variability between centres in these different countries. And you can now see the Swedish have actually moved themselves, they've got a much narrower distribution, and they're actually closer to getting nearly more of their patients below target levels. But this took place over 3 years of process of work. So we need to be persistent and consistent. Now that's partly a function of variability between centres. But one of the centres I worked with quite closely until recently was the Royal Children's Hospital in Melbourne. And one of the things that's interesting here, it's a very large paediatric diabetes centre, and we've got 8 clinicians. And their model of care is the clinicians all see their own set of patients, but in terms of the nurse dietetic care, all the nurses see all the patients. So it's a very interesting model because you can isolate potentially the effects of the different clinicians on the different on patient outcomes. And it was I have to say it's Fergus Cameron's idea to bring the 7 dwarfs in, and you'll see why as we go on. And what we first did is we actually wanted to check that there were robust and sustained difference in the different doctors in the care. So they've all got the same access to the same resources, same patient mix. We did looked at their care at 2 different time points, 6 months apart, just to make sure it had robustness. And what we found is there were consistent differences between clinicians in terms of the outcomes of the patients were getting. And there were some small differences between patients, between clinicians in their client mix, but these differences remain when we control for gender, age, duration of diagnosis, insulin regime, etc., etc. We still get these differences between clinicians. And so Fergus wanted to ask me, well, what's creating this difference between clinicians? In the same clinic, we're seeing the same clients, why would we get these differences? And so we did a little bit of a survey with the staff. And what we did, we asked them about metabolic targets, and there was very little variation within the team around what they were telling patients as the metabolic targets. We also looked at attitudes towards the importance of control, and again, we see very little difference between the clinicians. We've asked them about attitudes towards the emotional impact of diabetes, again, very little difference between them, and their attitudes towards patient autonomy. There's a bit more difference here between the different clinicians, but this, when we looked at the data, it didn't seem to map onto differences in patient outcomes. But the other thing Fergus asked me to do is, can we look at their personality? And in the psychology literature at the moment, we have one kind of very dominant model of personality, and it's called the Big Five. And basically what it is we think we can characterize people's personality along 5 broad dimensions. How extroverted versus introverted you've got, i.e. bashful. How agreeable or versus hostile, so how agreeable or not you are. So we've got grumpy over there. We have how open you are to experience. So how open you are willing to do different things, try different things out, and experience different things. So that openness to experience. I put nobody up there for some reason. We've got conscientiousness, so how conscientious you are, how likely you are to follow through on things that you say you're going to do, etc. I've put sleepy there for, obviously. And we've got neuroticism, or emotional stability. So how much you are an emotionally labile person. So you have lots of variability on emotions, or is your emotional stability quite low? So we assessed the 8 clinicians according to this a well-validated personality questionnaire. And because we've got these differences in outcome, and it's unlikely that the clinicians would all have to score the same on this question, we had a very simple rule. No 2 clinicians scored the same on the personality dimension, so every single one would be a threat. So we only looked for a personality dimension that showed a linear association. So there had to be a clear linear pattern in the results for us to go, this seems to be associated with outcomes. So anybody want to nominate which dwarf, for lack of a better word, gets the best outcomes? We've got a conscientiousness. So the good news about conscientiousness is they're all highly conscientious. Good news, all the doctors, very conscientious. So there's no variability there. So conscientious didn't predict outcomes because we didn't have any variability in those outcomes. It is grumpy. And the less agreeable the clinician, the better their outcomes. So the grumpier the clinician, so when you're thinking about going to the outpatient's appointments and you want to see a clinician, find the grumpy one. And the interesting thing for us is this effect, the size of the effect is the same as the difference we see between people using different insulin regimes, the effect of gender, the whole range of other variables. It's actually quite a strong effect that we found. And so what we're saying is that basically our clinician, somewhat attitude, but the way you interact is probably as big as an impact on the things that you prescribe in type 1 diabetes. Now, we actually don't think it's about being grumpy and being not very agreeable. What we actually think it is, when we've actually done some discussions, we've talked this through with the 8 clinicians, we think the difference is it's about being consistent. So our less agreeable individuals are more insistent and assertive about, we have to get to this target. It's not a negotiable outcome. The more agreeable ones will be talking about the fact, well, they'll appreciate how hard it is, but they won't put that degree of insistency there. Whereas our grumpy person has this tendency, he really, when we look at his consultations, he actually is much more insistent about, we have to do this, and less, and finding ways to get there rather than acknowledging we can't do it. So what I'd like to suggest that for healthcare systems anyway, a good clinical microsystem, I personally think at the moment you can characterise that because it's persistent, consistent and insistent about getting to the good outcomes that it's trying to get to. And that's my short talk for today. And thank you for listening to your ramblings, and I'm happy to answer any questions.
So,
yeah.
This grumpy sort of piss off his patients and lose them to the other doctors.
No, there's no differential attendance rates between the different physicians in terms of attendance frequency or regularity, like postponing. So we don't tend to see that. And I think the main thing is that they, what we see when we see the interactions, we video the interactions, is it's a bit of that, this persistency as well. They don't just let things go. We are going to find a way to make this work and find a solution.
Patients don't have a say, but if these were adults and you were talking about weight or hypertension, did you see that they would have a sort of self-selected group of patients?
No, so the patients here, so this is in the paediatric context, and I get what you're saying about the parents do it, but so the parents, when someone's newly diagnosed, they're just randomly allocated to the next clinician on rotation, and they're stuck with that clinician. So it's one of the advantages of this particular study is there aren't many centres that are like that, and that's what enabled us to do this. So we know they've had that same relationship, that same clinician. The interesting thing is one of the studies the video study group has done that I didn't present is they've actually shown those differences emerge within 6 months of a child being diagnosed. So within 6 months you can see these differences between centres. But yes, I think we need to replicate it, but it's we've got it published, so we're quite happy.
For my talk, can I suggest to you that the grumpy attitude might work well when the mother brings a toddler to the clinic, but when you are into the rush time, you lose that by grumpy attitude.
Well, what we found, like I said, with the what we've got here is children through to 18-year-olds in the study, and the effect when we've tried to kind of stratify by age and see if the effect's different, because you've got those age groups like adolescents particularly. Actually, we find the effect seems to be robust across the different age groups. So we didn't see any effects of what we thought might be, like you said, adolescents might be less happy with a grumpy clinician. But we didn't actually see any suggestion of that. The attendance rates were the same for each age group there. When we controlled for those kind of things, we couldn't see anything. But I have to say, as far as I know, this is the first study that's ever published data like this. So it's kind of a first study. We're trying to think about how we replicate and ask some of those questions about, does it work with adult clinics? Because there are lots of big adult diabetes centres around the world with multiple clinics. So we're at that point trying to answer that question. But we didn't see it. And again, when we look at the interactions, the thing that is interesting is that when we look at our grumpy, lack of a better word, our grumpy clinician, when he's seeing adolescents, the thing that we noticed about when we looked at those consultations on videos is actually he's much more focused in his conversations with the adolescents, whereas the other clinicians are actually more engaged with the parent. So we think that's why he doesn't lose the adolescents, because he actually talks to them, not through the parent. So that might be another confounding factor in there as well. Yeah.
Yes, I thank you. Teamwork. Did you notice any difference between the age of the clinicians and how they came out? And if you look at generations, supposedly the millennials will be better at teamwork than my generation. Is that? Do you see any? Did you look at that?
We haven't. We haven't looked at that per se, but knowing the different teams involved and knowing them from what they're actually very mixed. And I can't say when I think about the teams that were over here that they were particularly a different age group mix whatsoever. In actual fact, the two teams at the bottom here were probably the oldest groups. Oldest lead clinicians and mixtures. So, but we didn't formally test that. what we did find was some functions of the personality of the clinicians, and it was, what we find is the bigger teams, so we've got big and small teams. Bigger teams that aren't very collaborative do really, really badly. Small teams that don't get on with one another, they actually don't do so badly as a big team that doesn't get on with one another. But we didn't particularly ask that question, and it'd be really interesting to follow up.
Continuing on that, what about continuing medical education in teams?
Well, the clinical microsystem work says that's really a consistent predictor of good outcomes. It's systems, teams that focus on that. All of the problem is that's one of those things that didn't really vary between these centres, because we've got 21 centres who are all actively engaged in big collaborative research projects. They were all very much focused on that, and all of the professionals would come to the International Diabetes thing. So all of them had that consistency in there because of the nature of our sample. But clinical microsystem work says that's a really good marker of the system. It's teams that are really focused on that continuing professional development for all staff in the team. So that, yeah.
Thank you.
Yeah. Can you follow up? Can you look at specifically whether there's a difference in outcome in, say, healthy energy? When you follow these kids up, does it make a difference whether the kid sees the same clinician all the time, or one clinician now and another clinician next time?
So in the studies we've done to date, we haven't been able to answer that question. What we are doing that we are currently running our 5th study at the moment. They're just starting data collection in some centres now. The main thing, one of the things that we've got is with this one study, the last one I presented was done with children, so it's under 11-year-olds. We're now following that cohort, so we can look at that continuity of care. Have they switched clinicians? Is there continuity of care? If we go outside of diabetes, that continuity of care, though, is always considered as a consistent predictor of better outcomes. So if a patient is seeing multiple people, that's usually predictive of worse outcomes. All the big centres that I know in the study have a consistency of clinician, as in medic, but not necessarily in terms of the allied health team. So they may see multiple nurses, but they will see the same clinician, medic. But yeah, so we're looking at that.
In light of how important teamwork is, how can we build up a good team?
How long have you got?
No, just a short answer, please.
So for us, the most important thing we found is actually creating a space where you can have those conversations about what we're saying and what we're doing, and having that done in a non-judgmental way that doesn't get any arguments going. The easiest way is to have some team meetings, and what we found is having an external person come in and facilitate discussions about contentious issues. So you create that environment for discussion, and it doesn't happen overnight. It takes time to resolve and work through those opinions. So it can be difficult teams. That's one of the more interesting parts of my work, is I often get invited to go and help diabetes teams that are struggling and actually have a lot of conflict. It takes time, some interviews to understand what's going on, where the conflict, and then some structured sessions around helping people understand different people's perspectives. It's largely, it's often just people just not quite understanding why somebody thinks what they think and creating that space. So it's classical team, and I'm not one of those guys that you should go out into the wilderness somewhere and try and cross a stream blindfolded, all those kind of teamwork exercises. There's actually no evidence that any benefit whatsoever. Really glad to know. Yeah.
Thank you for the lecture. Maybe my question is not very intellectual, because I'm a surgeon. Well, I'm just saying that, well, I don't know whether it tells so much for future for the kids involved, whether it's 7 or 7.5. And I'm just asking, okay, teamwork is important, but did you follow each doctor for himself? If he sets the target on 7.5, and the one who finds it at 7,
yeah.
Is there if they have a consistency on 7.5, if you look at that, I don't know whether it is important or not, but I figured out that you mentioned that 7 was the limit that everybody should aim at.
Well, the guidelines are saying that you want to try and get below 7.
Yeah, but how is the consistency if you take just 7.5 and then?
Well, in terms of the impact on your long-term, those children's long-term health outcomes, if that's sustained over their life, that's vastly increases their risks of retinopathy, kidney disease, macular.
Only this 0.5.
Yeah, if it's sustained over a long time. It's one of the things that we know is that even small differences, because it's not just a one-off thing. What we see is that so one of the other things that this group and several other groups have now shown is, the level that you get within the first 3 years of diagnosis, following diagnosis, probably fairly close to what you're going to have for the rest of your life.
So
that does make a difference.
So you are saying that those are more educated than me and set the level of 7.5 and even 8. They are totally wrong in their medical.
No, I don't think they're totally wrong. What we're saying is that because they get some people to below 7%, they get some people above 7%. But what we're saying is those individuals who set themselves a goal with their clients of getting to a certain point are more likely to get clients to lower levels. So it's not about wrong or right. It's because one of the interesting things when you start looking at guidelines, so one of the things we quite often do is look at guidelines, and guidelines contradict each other all the time as well. You can quite often pick 3 different guidelines and they've set different target blood pressure levels, for instance, in type 2 diabetes. So it's not about whether, so I don't think this is about the targets. And so in this particular study, it's not the absolute value of targets that are showing up as the difference. It's whether the team are all working and saying the same thing to patients. And with our clinician, it's about how insistent they are on getting clients to that target. Because the person grumpy is not the one that's got the lowest target.
The reason for my question is just that, we are one microsystem maybe, with individual doctors facing most of the patients.
Yeah.
So there's not a big team maybe around the small specialties.
Yeah. In small, remote context.
So individual contact is very important.
Yeah. And in small remote context, that's true. But we also, if we take this to a type 2 diabetes context, there's some good data showing stuff, those similar things. But a patient with type 2 diabetes is seeing multiple clinicians in multiple contexts. And they are very rarely saying same information. And quite often we've published a nice study where we've actually showed they actually told the same patient 2 different things. It's about, if we want people to act, we need to be giving that consistent message. So it's not, our data show it's not necessarily the goal per se, but it's about these 3 things to a goal, so that everyone's trying to achieve the same thing. What we see a lot of the time, not everyone is trying to achieve exactly the same outcome. And with the Microsystem data that's been done has shown this is across all professional groups. Or microsystems, whether it's pediatric care, whether it's surgical care, whether it's intensive units care, we see these same kind of things. If the team is not being consistent, and insistent, you don't see as good outcomes. There is consistent literature about gender differences in patients. We don't see it with the clinicians in terms of men or women get better outcomes. There is some data done in primary care suggesting that you get gender differences in primary care, but it seems to be an interaction effect. So it's not that women do better or men do better, it's women do better sometimes with some people and male clinicians do better. But generally it's not a very strong, robust effect. We did look at it in our multi-center studies, and we don't see effects that women are better or not, which is why we didn't have Snow White on this picture. So we don't see that. It's the personality. So I've met some very grumpy men and some very grumpy women. So it's not.
You mentioned the Swedes.
Yeah.
The Swedes are very good at registries. Yeah. The diabetes registry is run by an Icelander, Sophia Guðbjörnsdóttir. Yeah. Does the effect, because they fill in the registry in each visit, I think. Yeah. So does the concept of having a registry that you fill in and it's over you the whole time, does it filter in into the microsystem
It's not what you put in, it's whether you're paying attention to and doing anything with it. And the reason I can say that is we have a Danish registry for type 1 diabetes, and there are substantial differences between the outcomes in Denmark, and that's not been changing since they put the registries in.
So having the registry, you must do it like this, it doesn't affect.
So putting the data into the registry isn't what results in better outcomes. It's actually looking at the registry, what's put in, and what you're doing, and trying to get change. And that's the big thing that the Swedes did differently, and they got a grant to do that work, is for the centres to look at their what they're putting in, and then focus on, well, what do we need to make a change? So you need the registry data, so you have to see the differences. It's then acting on the registry data.
So that is not automatically built in behaviourally when working in a registry.
No. So Denmark says, and one of the interesting things is I've been to one meeting where there was the registry data presented, and there were the different centre outcomes. And it was very interesting because the conversation wasn't about, well, what could we do to improve? It was about all the reasons why my centre isn't as good, because I've got this particular case mix and this particular thing. And what we see is you need to do the analysis to control the case mix. And that's the other bit that's not really done when you get raw presentation of registry data. They don't adjust for case mix, and that does affect the centre differences, but it doesn't fully account for them. You have to actively work in your team about what you're doing about these outcomes.
So, I just saw the day that somewhat surprising that if you want to succeed in the general context of what success is, getting money, getting to the top of your organization, unagreeableness is the most valuable thing you can have. But this was a very agreeable lecture. Thank you.